Welcome to QD Clinic. Hi, I'm Jack Cush with RheumNow. QD Clinic is brought to you by RheumNow.live 2025. We'll see you in Dallas, February 8th and 9th. An exciting meeting for sure. Today's case is called Autoinflammatory or Not. This is a 27-year-old gentleman I've been following for a few years. He was given a diagnosis by me of autoinflammatory syndrome. He presented with urticaria and daily fevers for a few months. When he was hospitalized and worked up, he really was quite sick. He had generalized lymphadenopathy, 2 to 3-fold elevations initially of his LFTs, 40 pounds of weight loss, anemia, hypoalbuminemia, a high ferritin of 14,000, an aldolase of 18, normal CPK, CRP was 113 per milligrams per liter. He had signs of heart failure, pericarditis. His ANA was positive, SCL70 positive. His TSH was elevated at 9. And again, because of the daily fevers, the urticarial rashes, the incredibly high acute phase reactants, including ferritin, serositis, arthralgias, he was called Still's disease and referred to me. In my evaluation of him, he does not meet my criteria for Still's disease, which is a major minor criteria, and he has 9 points out of 10. Look it up if you want to know. So I was unwilling to call it Still's disease and left open the opportunity for him to be called an autoinflammatory syndrome. So why would I make the distinction? Well, I don't want to get locked into a diagnosis and then locked into therapies and thinking. I think that can be a bit of a problem for both patients and those who manage those patients. Secondly, he has some atypical features, right? He has some autoantibodies going on. He has urticaria. Now, urticaria and pruritus is seen in up to 30% of patients with Still's disease. And it's actually a major feature of a lot of the other autoinflammatory syndromes, some of which are monogenic and inherited and seen in kids, some of which are acquired and seen in adults. So what autoinflammatory periodic fever syndromes are associated with urticaria? Number one comes to mind is Muckle-Wells syndrome, usually seen in kids, but can be seen in adults, including adults with an onset in their teens or in their 20s. The cryopyrin-associated periodic syndromes, or CAPS, that's, FCAS, Nomid-Sinca, and Muckle-Wells is part of that same triad. Still's disease, both in kids and adults, has urticaria often as a prominent feature. And Schnitzler syndrome, another adult acquired periodic fever syndrome associated with usually a monoclonal gammopathy. So this gentleman had a normal SPEP. He did not have a childhood onset. He had an adult onset around age 24, and he's now 27. So I have been treating him with steroids and anakinra. And anakinra worked well initially. 100 milligrams once a day, given at night. I give it at night because fever occurs at night in most of these patients, and the half-life of anakinra is only 6 hours. But in recent times, 100 did not control him. And while he did increase to BID or 200 at night, he could not afford it. Doesn't have the insurance. He's running out of anakinra, and he has activity. He said that when he went back from BID to once a day anakinra, once a night anakinra, his fevers started to recur at 103 degrees every night. He was having some more aches and pains and back pain. He did not have side effects with the anakinra. That would include injection site reactions or painful reactions or low white counts or infections. So the question is, how are we going to manage him? His most recent lab tests are not good. His aldolase is 12, still elevated. His CK is 72, normal. While his SED rate and CRP are normal, his LFTs are elevated. His AST and ALT are 60 to 70. His ferritin is 2,500. And his H&H is normal, 14/47. And his white count is 4.1. Really confusing. Now, I say he's active, and you would say he's active because of the ferritin. I say he's active because of the aldolase. In my hands and the hands of others that have managed these syndromes and patients at UT Southwestern, aldolase is the single best biomarker for patients with Still's disease and the IL-1 responsive autoinflammatory syndromes. And that's showing up here. His aldolase is still 12. When he was diagnosed, it was 18 when he was at his worst. And again, he does have a normal SPEP. So the question is, how are you going to manage this gentleman? I still will call him autoinflammatory syndrome. And the treatments that would work in him are going to be steroids. We'd like to avoid that. Methotrexate in combination with other DMARDs, not always very effective. I think that the drugs that we should use would be IL-1 inhibitors or the IL-6 inhibitors or JAK inhibitors. Now he's in a situation where he doesn't have insurance and his income is low. You can apply to the manufacturer to get compassionate use drug for either, not so much for anakinra, that's kind of hard, but for maybe the other IL-1 inhibitors, and that include canakinumab, which is a long-acting drug. Go for either sarilumab, the IL-6 inhibitor, or the use of tocilizumab, which is FDA approved for use in systemic JIA. And we now don't distinguish systemic JIA in adults and kids or Still's. It's Still's disease. It's the same in adults and kids. And if it's approved in one, it's approved in the other. So you can get it approved that way. So that's what we did. I told him temporarily to go up on his methotrexate, try to continue to take his anakinra. I started him on methotrexate as a steroid-sparing move. Not sure if that's going to work very much. And in the meantime, we're going to apply for compassionate use canakinumab. These can be difficult cases. By the way, we'll see you at RheumNow.live, where we've got a great session on RA, where we're going to talk about AI in RA, artificial intelligence in RA, managing older patients in RA, and we got Brian Englund talking about multimorbidity management in RA. Our RA speakers include Una Macris, Jeff Curtis, and Brian Englund with a great panel discussion afterwards. We'll see you at RheumNow.live.